We have blood. So here we have a mess. And we also have increased blood pressure. Whoa. Welcome back to our physiology series. This is part 3 where we're discussing shock and compensation. If this is your first time checking out our channel, welcome. And hit that subscribe button down there so you are alerted of any future videos we post, and make sure your notifications are turned on as well. Leave us a comment if you have any questions regarding this video or any feedback for us, and hit the like button if you find this video helpful. This is part 3 of our series, so if you haven't seen part 1 and part 2, this is going to kind of build on those, so go back and check those out. We'll put a link in the description below. So today we're discussing shock. Well, why is shock important? Why do I need to know about shock? Well, if you're gonna do anything medical or trauma related for somebody, you need to understand shock. The reality is everyone dies from shock. As an injury or illness progresses and gets worse and worse, a person eventually goes into one type of shock. And then that person, if that person ends up dying, it was a result of some type of shock. Now, that shock was caused by something else, which is why there's different categories of shock, but ultimately there's some form of shock that this person goes into. And that's why if we can break this down to determine what types of shock we're dealing with, then that helps us to know how we can treat this patient better. So what is shock? Well, the technical definition for shock is hypoperfusion or low perfusion. Now perfusion, if you remember from some of our other videos, perfusion is where we have gas exchange into the cells. Our cells need oxygen and glucose to survive. A bunch of other stuff as well, but let's break it down to the main components, which is oxygen and glucose. Oxygen comes in form of breathing. You breathe air in, you bring the oxygen into your system. We have the red blood cells that are transporting our oxygen over to our cells. We have the oxygen that is bound to our hemoglobin. The oxygen jumps off at the cells where it's needed. The byproduct of our metabolism is CO2. So our red blood cells pick up the CO2, and really our blood is going to absorb some of that CO2 that may not even be attached to our hemoglobin. But either way, we now transfer oxygen for carbon dioxide. That carbon dioxide then comes back through our venous system, back to our lungs, and when we exhale, we blow out that CO2. So perfusion is the process of exchanging that gas at the cellular level. Oxygen moves into the cells, the carbon dioxide comes back out, and we have that perfusion perfusing those cells with the oxygen they need. Glucose comes from the food we eat. So as we eat food, it breaks down into sugars. That sugar is transported to the cells. The cells also take that sugar, and they use the sugar and oxygen to produce energy, and then we get that carbon dioxide as a byproduct. So remember, when we're talking about shock, shock is hypoperfusion or low perfusion. For some reason, we are not getting the oxygen into the cells. It may be a lack of oxygen. It may be a lack of red blood cells. It may be an issue with the heart pumping the blood. We may have everything loaded up, but there's not a heart strong enough to be able to pump that to the cells. But for some reason, the cells on this side are not getting the nutrients and oxygen they need. That's low perfusion, and that is what we are calling shock. So let's dive in now and take a look at the different components of our circulatory system. When we look at those, we'll be able to then figure out, well, what part of the circulatory system is failing right now due to this certain injury or illness, and then that'll lead us into what type of shock we're dealing with so we know better how to treat these patients and how to start compensating and helping the body compensate for this illness that is affecting our patient. We have blood. Okay, so here we have a mess, and this mess is going to help us illustrate how our body distributes blood. First off, if you use red food coloring, you should probably wear gloves. It's just messy. It's gotten everywhere. My hands are now stained. I'm not sure whose idea it was to use red food coloring in this instead of just using plain water.
That was your idea.
Oh, yeah. Anyway, let's dive into this. So, when we're looking at our circulatory system, we have 3 main components. See, there's the red. 3 main components. We have a pump. That's our heart, represented by this bulb pump here. We have the fluid, represented by my water with food coloring. And we have the container or the pipes. So our pipes are the container. We have pipes that transport this around, but they also act as a container because there's volume that can fill up these pipes. So we're going to use the term pipes, which is all our blood vessels, arteries, and veins. But remember that this is a container. This is what holds our volume. We don't actually have a tub in our body somewhere that sits and holds this blood. It's all distributed through all the veins and arteries. So we have our pump, we have our fluid, and then we have the container or the pipes that holds all this and uses it to transport it throughout the body. Okay, so we have 3 different main components of the circulatory system. So how many main types of shock do you think we have? 3. Very good, 3. So 3 different types of shock we're going to talk about. Now, some of you out there maybe, no, there's 5 different types of shock. There's 6 different, 7, okay. Depending on what textbook you look at, there's different categories or different ways people categorize it. Some people, in the simplest, rawest form of shock, will categorize it in 3 main categories, which is how we're going to do it today, because there are 3 main components that could be failing. 1, cardiogenic shock. That means we have a pump problem. Cardio, cardiac, heart. When there's an issue with the heart and the heart is not performing like it needs to, we have cardiogenic shock. When we have an issue with low volume, or we have issue with the blood supply, whether it's dehydration or blood loss, we have hypovolemic shock. Hypo means low, volemic is volume. We have low volume. So if we have low volume and that's contributing to our shock, we have hypovolemic shock. The third is going to be an issue with getting the volume. The pump may be fine, the volume may be fine, but we have an issue getting that volume out to where it needs to go, out to the cells, and that's a distributive shock. So when we have an issue with the pipes or the way that the body is distributing that volume from the heart out to the cells, now we have distributive shock. And there's a lot of different types of distributive shock. We have anaphylaxis, which is allergic reactions, severe allergic reactions. We have neurogenic shock, which is an issue with the nerves telling the body what it needs to do to compensate. There's other types of shock that we can put under this distributive category. Obstructive shock presents issues with distributing. So all these other categories we could fit under the distributive side. So for the simplest form of explaining this, we have 3 categories. So I'm going to put on some gloves here. I'm not sure why, because my hands are already stained red. And I'm probably going to get everything else stained red here as soon as I start splashing water around. That'll be part of the fun process. So let's break these components down. I'll show you really quickly how we have this set up, what we're demonstrating, and then I've also got some different size tubing when we really start talking about distributive shock. So I've got my pump, got my fluid that's going to make a mess, and then I've got my arteries that are going to be, oh yeah, definitely making a mess. This was a great idea. Okay, so if you can see, I'm barely squeezing this bulb, and we are getting a decent amount of distance out of the fluid that's coming out of this tube. This tube is our medium-sized tube, so I've got one smaller, and I've got one larger. I am barely squeezing this bulb. Not much pressure, and not a lot of volume, but we're still getting some good flow out of there, and we're getting good distance. So the distance you're seeing out of this fluid is due to the pump that's pumping it, the fluid that's available to it, and the size of this tubing that we're using to push through it. So we're using this distance to represent blood pressure, to show you blood pressure and how much pressure we have in the system. We have enough pressure to push it through the pipes, get it where it needs to, and adequately perfuse the cells with this one. I also have a couple different sizes. I have a couple different sizes of tubing. So we have a larger one here. So as we hook in the larger tubing, we're not going to have that amount of pressure, that amount of squeeze on the fluid. So as the heart is doing the same amount of pumping, and we go through a larger tubing now, we're not going to have that much pressure. It's going to more trickle out, which we'll show in a little bit. Then I have some small IV tubing here. This constricts down even more. So now my heart actually has to work harder to pump against the smaller tubing. So it'll decrease some flow and the amount of volume that can go through, but it'll increase the blood pressure. So we actually will be able to continue to get that blood pressure out to the cells where it needs, with the heart doing some of the same amount of work. So we'll play with these in a minute and kind of hopefully visualize some of these different shocks. One more thing that I want to talk about before we dive into the different types of shock. There's 3 different terms that I want you to keep up with, and these terms are going to tell us what's going on with each one of the components, the heart, the pipes, and the fluid. So with our heart, we want to measure heart rate. How many times is our heart beating in a minute? That's a diagnostic tool that we can assess on a patient. We can check their radial pulse and we can determine heart rate. So as we work through these things, let's track our heart rate and what's happening with our heart rate. For our fluid, let's track our amount of fluid in the body. You're not going to be able to do this on a scene, but we're going to use a number as we work through these to show you what's kind of happening. So we're going to talk about liters of fluid in the body. Then for our distributive system, our pipes, for our container, we want to talk about SVR, or systemic vascular resistance. That's the resistance inside our vessels that is adding some of that extra squeeze and pressure to our system to keep that blood flow moving. So our SVR, we're simply going to say up or down, volume of fluid up or down, and then we'll talk about heart rate. Is it going up or down? First type of shock, cardiogenic shock. This is a problem with the heart. So if someone's having a heart attack, that's one of the most common types of cardiogenic shock. CHF, congestive heart failure. When you have a heart that has some disease process over time and it starts to die over time, it's not a sudden heart attack, but it's more of a chronic, long-term issue. And now that heart muscle is starting to die, it's losing some of the squeeze to that heart, and thus it decreases the amount of volume it can actually push through the vascular system or the pipes. So we have a heart that is no longer pumping as hard, and we have less flow coming through our system. We have less perfusion. What's our definition of shock? Hypoperfusion. So heart's not beating like it should, whether it's doing it really slow, or whether it's doing it at the same rate, it just can't get as much volume with each one, with each time it beats. We're going to have less fluid getting to the cells. So we have low perfusion, we have cardiogenic shock. So what happens? Our heart rate is maybe going to stay the same or maybe increase. The body may say, we're not getting perfused, we need to increase heart rate. It may try to beat harder, but because the heart is now dying or has problems, it either may not be able to beat harder, or it starts beating harder and it speeds up the process of actually destroying the heart. So we want to reduce the workload on the heart here. What also is going to take effect? Well, the fluid, there's not going to be any volume shifts. The volume in the body is what it is. We're not losing blood, we're not losing anything, so that doesn't really change, so that stays the same. And then on our pipes, what's going to happen with our SVR, or our vascular resistance? If we have decreased volume and we have decreased pressure because the heart can't squeeze hard enough to get that good pressure, we're going to have a smaller, we need a smaller pipe to help give some extra squeeze to keep that blood pressure up so it can continue to propel that fluid through the body. So let me swap this out with a smaller pipe and we'll show you the difference here. So I have a smaller tube on here now. Oh, dangerous. Everybody's getting stained red. Okay, so we have decreased the pipe size, which represents increasing our resistance, or the systemic vascular resistance, our SVR, in our vessels. So we have a pump problem. The pump is not pumping as hard. We squeeze down on the rest of the vessels, and now we have better blood pressure at the cells so they can still get perfused. Now keep in mind, this is not optimal. We're still not getting large amounts of volume and fluid moving through there, but we have better pressure so it can at least reach the cells and perfuse the places it needs to. It's not as much fluid as we would like, but it's the body's way of at least compensating to get a better pressure to continue to transport these oxygen molecules to the cells. Not perfect, but it's better than if we did nothing. So a couple things happens when we have a form of shock like cardiogenic shock. One, things squeeze down. Our vessels squeeze down. Those arteries and vessels will squeeze. They have smooth muscle in there. They will squeeze down, constrict, increase that blood pressure so that you can continue to propel that fluid to the cells where it needs to go. Two, as it's squeezing down, it squeezes down more in places like the extremities and the stomach and some of these places that are not as essential for life. So the body says, okay, we've got all these organs and all these parts of the body. We need to kind of prioritize. We need blood flow. We have issues with the heart where you don't have as much fluid moving through. So I need two things to happen. I need to get a little extra squeeze in the core so we can continue to move some of that. And then I need even more squeeze on the extremities and some of these things that are not a priority so that we can move the blood to the areas that are a priority. So what would be a priority? Brain, heart, lungs, even kidneys. So some of these things are priorities for the body to be able to continue to function. The fingers and toes, it goes, well, you know what, we don't really need those right now. Let's just go ahead and constrict those down a lot, decrease the amount of blood that goes out there, and that'll push most of the blood back to the core, to the vital organs. So we have blood shunting going on by the squeeze, and we also have increased blood pressure. Whoa, almost got red stuff everywhere. Careful there. And we have the vessels inside the core that are squeezing down to be able to continue to increase that blood pressure. So issue with the heart, we compensate by squeezing some of the vessels to keep that blood pressure up. So we have two different stages of shock, okay? So our heart rate, or our heart is beating. We start to have a decrease in pressure. Our body starts to squeeze those arteries to compensate for that to keep our pressure up. So we may see an increase in heart rate now as it's now compensating and trying to work harder. We have an extra squeeze or increased SVR that is now compensating, and that keeps our pressure, our blood pressure, where it needs to be. As we're tracking this patient and we know, hey, they have cardiogenic shock going on, we're monitoring them. At the point where we start seeing that blood pressure drop, we move from a compensated shock to an uncompensated shock. The blood pressure is our determining factor to say, is this person compensating on their own or with whatever we're doing, or are they going into uncompensated shock where their body says, we've tried everything we can't keep the pressure up, we're failing. At the point where the blood pressure starts dropping, that's critical for that patient. They've gone into uncompensated shock and their body's basically saying, we've tried what we can and it's not good enough to keep this pressure where it needs to be. So the person is now trending down, that's a bad sign. So remember, our blood pressure, determining factor between compensated and uncompensated shock. Okay, so our next type of shock is hypovolemic shock. It's low volume. It's either by severe dehydration or if we have blood loss of some form. Somehow fluid in our body has left. We don't have as much fluid to work with now. So as we have our fluid that has decreased, our ways of compensating for that are to increase heart rate and increase our SVR. A little bit extra squeeze on the arteries, a little bit faster heart rate, and we can take the smaller amount of fluid that's there, circulate it to keep our blood pressure up and keep it moving faster to make up for the lack of fluid. If we have 5 liters of blood in our body that's circulating in a minute, and now we only have 4 liters to work with, if we pump faster, we can transport that oxygen through the body a little bit faster and compensate for some of that decreased perfusion or shock that we're dealing with. This is a little bit hard to explain with this setup. So I have large tubing, I have fluid still moving through. As you can see from our previous cardiogenic shock, I was getting much more distance, much more pressure out of here, so I have a larger tubing. So really the best way to continue to keep this up would be to decrease my tubing size, give a little bit of squeeze on there, and also, if my heart works a little bit harder, I can get more fluid and more pressure out of my heart. So again, this is a poor illustration for the fluid. I don't have a good way to demonstrate low volume in the pipes and in the container system like this. But hopefully you can at least see what would be compensating in the body for this. So you have decreased volume, you're going to have to increase heart rate in the work on the heart, and you're going to have to increase SVR to compensate for that low fluid volume. You lose too much fluid, the body can't keep up, so you start to see that blood pressure drop. That patient has gone into decompensated shock. That's a bad sign. This patient is digressing quickly. We need to do some sort of intervention for them because the body has done everything it can up to this point. We need to make sure that we get a blood transfusion or something similar on board for this patient to make up for that lack of volume. Okay, our last type of shock, distributive shock. Now remember, this is kind of a category for a bunch of different things underneath it. Under our distributive shock, which distributive just has to do with distributing the blood out to the body. These are our pipes. This is our system that takes the blood from the heart and gets it out to the cells. So all these work together, but now we have an issue with distributing it. We have a couple different subcategories of that. One would be obstructive shock. Obstructive shock is when we have some sort of obstruction that keeps that blood flow from moving. So this could be a blood clot. This could be like a PE, something in the lungs. Now you have a PE, a blood clot, pulmonary embolism in the lungs. So as the blood is moving through, it hits this roadblock, it can't move through, it moves through some of the vessels, but other vessels are blocked, and now we have a decrease in blood flow moving through there. It's an obstruction. It's a type of obstructive shock. So what do you think is going to take place if we have an obstruction? If we have multiples of these tubes and one of them gets blocked, but we still have to continue to get perfusion through, what do you think is going to happen? Well, we're going to have, our heart is going to start working faster. So an increased heart rate is going to be one of the first things you see in a lot of types of shock, unless there's some specific reason that heart cannot beat faster. But that's going to be the first compensating mechanism. So if there's an obstruction and we're not getting as much flow through, but there's still some vessels that blood can flow through, the heart's going to increase and try to speed up things to get more blood flowing through the available and open passages, even though we have a blockage in one or a few of the passages as well. Another type of obstructive shock would be a septic shock. So if someone has an infection and then that infection gets in the bloodstream, it goes septic, that person is now sick, has a widespread infection in their body, the body is going to react to that in certain ways. One is vasodilation. So the vessels are going to dilate. We're going to have a bigger tube now. So with septic shock, we have bigger pipes now. And what happens when we have bigger pipes? We have a decrease in blood pressure. So someone's septic shock, we have decreased SVR, or systemic vascular resistance. Once that's decreased, we see a decrease in blood pressure. So how do we compensate for that? Well, we could, as a medical provider, we could give fluids. We could give IV fluids, which is one thing we do for septic patients. We could also give vasopressors to help additional squeeze, but the body itself is going to now increase the heart rate to make up for that vasodilation that you get in the body due to septic shock. So we can combat that some ways with medicine, but the body's first response is to increase heart rate, make it beat harder and faster to make up for the decreased volume going through these bigger pipes now. Another subcategory of distributive shock would be anaphylaxis. So anaphylaxis is a severe allergic reaction, not just an allergic reaction, not just, hey, I ate some peanuts and I got a little bit of rash. Anaphylaxis is when your body goes into shock from allergic reaction. A couple of things take place when we have anaphylaxis. The bronchi in your lungs will squeeze down. They will constrict, decreasing airflow. So that is a type of obstructive shock with that. We also have a distributive aspect of that where our vessels now will dilate as well, kind of like the septic shock. They dilate. We have decreased blood pressure due to that. So now we're going to have an increased heart rate to help overcome that. You're going to start breathing faster because you have decreased oxygen moving in your lungs. You're going to have a decreased blood pressure, so your body's now going to increase the heart rate. And then we're going to give epi as a treatment for that. That epi is going to help with some squeeze to constrict down on the vessels. It's going to help open up the airways. And as a byproduct, it's going to make the heart rate go up a little bit more, which could in turn potentially help the body compensate, but the heart rate's probably already going to be up from the body's compensation, so it's kind of more of a byproduct we get. The main thing we want is we want the extra squeeze on the blood vessels, and we want the opening of the airways that are now constricted due to the anaphylaxis. So the last subcategory we're going to talk about in distributive shock is neurogenic shock. Neurogenic shock is an issue with the nerves, or specifically the brain or spinal columns. So remember, your brain is the computer that takes data from your body and says, oh, we're losing blood. And then it takes that data and says, you know what, to compensate, we need our heart to beat faster. So the brain says, heart, you need to start beating faster to compensate. Your brain is kind of your central computer that's processing all this data and figuring out what the body needs to do. Well, let's say we have an issue with the nerves that send messages from the brain to the body, or we have an issue with the brain itself to where the brain can't send that data out and process that data. Now we have the nerves, neurogenic shock, taking place. The heart is fine, the pump is fine, the volume may still be there, and the pipes are still doing what they need to be doing, but they no longer have a form of communication that tells them they need to squeeze down or heart rate needs to increase or all these things. So this is frequent in trauma. You have someone that falls a large distance, someone on a motorcycle accident or even a car accident. But when you have trauma to the spine or the head, you now have issues with the body or the brain being able to communicate to the body and the body being able to talk back to the brain. So you may have an issue and the body has no way of compensating for it. So these patients are typically going to be trauma patients. You see them, oh, this person has flown off a motorcycle. You go up to them and you notice that their blood pressure is low, and you feel a heart rate, and the heart's not compensating like you would think. Typically, our heart rate would go up to compensate for lack of blood or distributive issue. The heart rate would be the first thing to compensate. Well, the weird thing with neurogenic shock is that heart never compensates. It never goes up. So we're sitting here checking a pulse and we're like, why is our pulse rate at 60? We have a low blood pressure. This person was a trauma patient. And they may not even be pale and cool. If you see someone that's pale and they're going in some type of shock, that's because the vessels, remember the vessels in the extremities constricted, so there's not as much blood flow to the vessels on the outside because it's pushing it all to the core where it needs it. So they're going to look pale, cool, they may be sweaty because they're going into shock. These neurogenic patients are not going to have that because the body's not constricting to move that blood inside. The body's just like, I don't know what's going on. All form of communications have been cut off. I have no service on my telephone. My phone line's been cut. There's no communication back and forth. So the body has no idea of what it should be doing to compensate for whatever issue there is because there's an issue with the communication from the brain to the body. That's why it's so important in these patients for us to hold their spine, maintain a proper C-spine alignment, so that if there is a fracture or an issue, we don't make that any worse. And then we have to be very proactive in monitoring these patients, keeping up with vitals, and making sure we're treating these patients as best they can because their body cannot treat and compensate for these issues at hand. Okay, quick recap. Shock, hypoperfusion, low perfusion. We're having an issue getting oxygen to the cells. There's a variety of different reasons why that could be a problem, and that's where we break into categories for the shock. 3 main categories: cardiogenic, having to do with the heart; hypovolemic, having to do with low volume; and then distributive, something with our pipes or the system that distributes this blood is having an issue. And then there's subcategories under that. Remember, our body's going to try to compensate in one form or another. So if we have low volume, we can give extra squeeze on the pipes and we can increase our heart rate to be able to overcome the lack of volume. If we have an issue with the heart, we can give some extra squeeze in order to be able to overcome the lack of pressure that our heart is not producing. If we have an issue with the pipes, we're going to have an increased heart rate to overcome the issue with the pipes. So keep in mind that the heart rate is one of the first signs you will see with someone that starts to compensate. So you have someone that's going into shock and you're starting to assess their vitals. It's normal to see an elevated heart rate. That's one of the first things you see when someone loses blood, when someone has been in an accident. You're going to see that just from a scare of someone in an accident or a traumatic event. You're going to see that heart rate increase because they're shaken up. You'll see that heart rate anyway, but as you're monitoring vitals, you're going to see an increase in heart rate for someone that's compensating. A late sign of the compensation and something that shows you that the body is now decompensating is a decrease in blood pressure. Once you see that blood pressure start dropping, that is starting to get critical for that patient. The patient's body can no longer keep that blood pressure up to continue to perfuse the vital organs. One important point I want to mention: shock is not when you are scared. People are like, oh, he just had a car wreck, he's in shock. Well, okay, he's shook up, he's in shock, sure, but that's a loose form of the word. That's not what we're talking about here. We're talking about, very specifically, this patient has hypoperfusion for some reason, okay? So just because someone is all shook up and scared does not mean that they are in a medical type of shock. Well, that's it. That wraps up our talk on shock. Hopefully this broke it down for you to where you could see some of the differences between the type of shock and you can start to recognize these. As you're assessing patients, as you're taking people's blood pressure, keep these things in mind. Keep going over this, because if you don't have this in the back of your mind for what's happening, it's going to be much harder when you do see someone that's in shock to be able to take those vitals and remember what's happening with these patients. So continue to review these things. Hopefully this video was helpful for you, and as always, stay vigilant and stay safe.